Woman, an in-depth exploration of the world of women today with Sandra Elkin.
Good evening and welcome to Woman. Tonight we are going to continue discussing mental health care for women, what's right with it and what's wrong with it. My guests are Dr. Seiden, a practicing psychiatrist from Chicago, and Dr. Naomi Weisstein, professor of psychology at the State University of New York at Buffalo. Welcome to both of you once again.
Hi.
Naomi, why do women go to therapists?
I think women go to therapists because they're unhappy. And I think that if you ask an individual woman patient, why are you going to the therapist? She'd say, well, I have these problems and I can't solve them and nothing seems to get better on my own and I'm going to somebody to help me solve them. So I think that at one level the answer is simple. Women and people in general go to therapists because they perceive that they have certain kinds of problems that they can't solve themselves. I think there's another level on which you can ask that question. You can say, why is it that more mental patients are women than men? Why is it that mental patients generally tend to be women? And there you get into a whole question about what the society is organized like, such that women decide that they're sick or are diagnosed as sick or have to seek help. And in that sense, I think that you can talk about women living in a society which does not like them, which thinks they're inferior, which treats them with contempt. And there are two responses that a person can have to a society which does not like that person by virtue of something the person can do nothing about. One of the responses is to internalize what society thinks about that person. And the other response is to get very, very angry at certain agents in the society who think that. In other words, women can either hate themselves or they can hate other people. Now, neither response is going to make for good mental health. Women are taught to love other people, to care for them, to nurture them. It's very difficult for women to express rage. That's taught out of them at a very early age. So that either way, if they've got feelings of rage towards themselves, or if they've got feelings of rage towards people who, for some reason, they feel aren't treating them right, they have no way of effectively expressing that rage. And one of the institutions which is set up to help them express that rage or do something with it is the institution of therapy.
Anne, did you want to comment on that?
Well, I think there's a great deal to all of that. I also think it's important to realize that that men do seek therapy as well as women, and I wouldn't want someone to miss the point of what you're saying by virtue of the fact that they know some men who are in treatment also. It seems to me that women seek therapy by and large for the same reasons that men do, at least those men who do seek therapy. They are miserable, they want help, or they're behaving in ways that lead someone else to decide that they need help. That happens to women as well as to men. And in terms of outpatient treatment settings where the treatment is most likely to be pure psychotherapy, women more often than men will come in. But I think there's another aspect to this which reminds me a little bit of what you were saying earlier in the discussion that was presented last week. That one part of therapy, and we may disagree because I don't think it's the only part, but one important part of psychotherapy is the kind of sympathetic listening that a good friend or a skilled listener can provide. That makes a person feel less alone with their problems, creates an atmosphere within which the person can think more constructively about their problems, and maybe think of something that they can actually do about the problems to actually change it. It takes a good listener, someone who has an ability to be empathic, and someone who has listening skills. And I think one of the reasons that women may seek this out somewhat more than men do is that women have been trained in just those skills. And many men get a kind of informal psychotherapy from women, which women can't as securely count on getting from men, although many women do get it from many men, and that's the basis of some very valued relationships. But some of the kinds of data that bear on that are what happens to widows and widowers, and it's really really interesting that men in general seem to be able to handle being widowed less well than women do, and sociologists who have studied this feel that in part it's because women are more likely to have a woman friend who is a confidant even though they are married, and perhaps have several people that they can talk with, whereas there are alarmingly large numbers of men who have no confidant other than their wife, and if they're not married, perhaps no confidant at all. And it's interesting that the statistics on seeking or needing therapy for men are different depending on whether they're single or married. The difference with women is much less than the difference with men, and goes in the opposite direction. For men, not being married is a mental health risk. For women, being married may be a mental health risk, depending on a good many things about the quality of the marriage.
There are some people who say that women are isolated from each other, and that could also, I suppose, add to your reasoning.
Some women are very isolated from each other, but many women are not isolated from each other. One of the interesting things in our society is that large numbers of women continue to have very cherished friendships with other women, which are enormously valuable in making life more worthwhile and stabilizing their mental health, and in all kinds of ways is one of the good things in life. It's interesting that this has continued to be so, more, I think, than people realize. It's perhaps less true for women who move around a lot, because they're likely to break up those friendships. When those friendships are strongest, they often have started in girlhood and continue throughout life. They may be with close old friends, they may be with relatives. And for some women who reach the public eye because they've done things that have involved moving around, leaving the place where they grew up, they may not have the same kind of long-lasting friendships that many women, including, I'm sure, many of your viewers have. I think one of the real tragedies is that some women are taught to not value their friendships with women as much as they otherwise might. In high school, there are girls who are encouraged to break plans to do something for an evening with their girlfriends if they should get a date. There's a tendency to, in a sense, treat female friendships as a sort of farm team where you practice until you get to the big leagues where the real action happens, which is viewed as being relationships between men and women. But relationships with men are only part of life for women. It's that part that has been more celebrated in our movies, our television shows, our short stories and novels, and the very real and lasting and valuable importance of relationships with other women, although it has continued, hasn't had the attention that I think it deserves.
I'm interested in discussing some specific complaints, and I'm very interested in depression, and would like you to talk about that a little bit.
Depression is considered a prototypic women's illness in a sense. Most of the studies of incidence of depression show a really clear-cut difference. Somewhere around 3 times as many women as men are likely to be treated for depression. It's a little bit hard to interpret that because, again, more men are likely to have alcoholism still, and some people would view that as another form of expressing depression and say that perhaps the incidence isn't as different, it's just in how it's shown. But certainly among patients who come to treatment for depression, many more women than men will be found.
Naomi, did you want to comment on that?
Yeah, I think that it's a very interesting kind of symptom. One of the things that happens when we talk about mental health is I think that the discussion necessarily wavers back and forth between talking about people who are, quote, normal and are unhappy and people who for some reason think that they're kind of crazy. And I think that the distinctions are really terribly blurred, both in the eyes of the public and also in the eyes of therapists. Well, we know that distinctions are blurred in the eyes of therapists because there are a lot of studies which show that therapists really can't tell the difference. Well, let me say it a different way. There are a lot of studies which show that a therapist who diagnoses a given patient on a given day as being, let's say, schizophrenic or depressed or hysteric or whatever the category is, 3 months later, seeing the same intake interview and the same bunch of tests and the same thing from that same patient, chances are will give a different diagnosis to that same patient.
I have to make some comment on that because there have been a number of studies. Some go the way you say, others go the other way.
Okay.
It's not established that it's a random
Okay.
process.
Although there are a number of studies which seem to say for this particular sample, it's fairly random. Let me just get back to depression and talking about that, because I think that in that case, it's really difficult to distinguish depression from unhappiness. I mean, a lot of people ask, how do you know you're depressed? Well, you know you're depressed. What's clinical depression? Clinical depression is maybe you can't get up. You sleep all day. You're too depressed even to commit suicide, something like that. On the other hand, nobody would make the cutoff there. I mean, nobody would say, if you're not clinically depressed, if you're not that depressed, then we don't want to see you, you're just unhappy. And so it's various gradations of not wanting to move, of thinking that there's nothing out there that's going to be satisfying, of saying, why should I get up this morning, of saying, what is it? What kind of not being able to work, all the kinds of things that go into the common complaints which make up depression. So when the statistics are quoted, okay, 3 times as many women as men come in with this complaint of depression. Again, to me it says, wow, this isn't a mental health problem. This is a society problem. This is a problem that has to do with a society which treats women so badly that they're depressed, that they're unhappy.
We might have an argument about whether we were willing to consider that there is an illness, depression. I think there is.
Mm-hmm.
I think it's a little bit like in the old days there used to be an illness called fever. Remember there's a song, she died of a fever and no one could save her? Fever was the name of the illness. Now we know more. We know that there are a number of different causes of fever, and the appropriate treatment for one may be beside the point for another. But at one point, people in grouping illnesses could see that all these people had this thing in common and called it fever. I think among the people who feel depressed, there can be a variety of different causes, and that I think that clinicians ought to be able to do the best that's possible at any given time to work with the patient to figure out what are the causes for her feeling this way. And among those causes, I do think there are some people who have an illness which responds very dramatically in some cases to medication as well as to therapy. And I think it's terribly hard for the individual to know. Now, there are people, of course, who, knowing that, will pass out pills without listening to the patient. I'm not defending that either. But I think that it's terribly important for people to know that if they're feeling persistently unhappy, that it could be an illness which could be treatable, and that a good clinician ought to be able to work with them to figure out what the causes are, and that rather than go on thinking that that has to be their lot in life forever, they ought to talk to somebody, and they maybe ought to talk to several people, and maybe that they'll want several opinions about it.
I really agree with you. And I think, again, it's really interesting that the area of agreement is where you say, well, there's pills for this. Because I think that in certain cases, and we don't know very much about these cases, when we isolate problems, medical problems for things like depression or hallucinations, things like that, and we talk about drug therapies, all of a sudden light breaks at the end of the tunnel. You say, well, maybe there is some way out. When we get back to insight therapy, when we get back to let's look at depression and let's find out the causes in your head and so forth and so on, I'm back saying, I think that maybe, while I agree with you that a friend can help and a therapist can be a friend, I think we're back to social causes. And let me just, I keep saying social causes, social conditions can change behavior. Let me just give a couple of examples. There was a very interesting article in the New York Times where they took convicts, and again, they had a control group, a group that they do nothing on, and they had an experimental group. And the experimental group got plastic surgery, and their faces were made over. The scars were removed. They were made to look like nice guys. And the rate of going back into incarceration, the recidivism rate for the experimental group, for the convicts whose faces had become very pleasant to look at, dropped dramatically.
Okay,
Now,
but
course,
I think a good therapist ought to be a good diagnostician and who might well consider that form of treatment.
Sure, sure. But then what we're saying is, when you talk about therapy, you're talking about somebody who says, who would be able to say, look, this is a social problem. Your problem is that you're a woman, and this society does not like women. Versus your problem may be biochemical, and let's try you on this drug and see if that works. I think there are very few therapists around who will say, your problem is that you're a woman. I mean, they'd be out of business.
Naomi, let me ask you this. Do you think it would be helpful to examine some of the evidence that's used to construct theories about women?
Well, sure. I think that, for instance, again, classical therapy, by which I don't mean just Freud, but the insight therapy and the whole clinical tradition, the theories about women have come from, quote, years of intensive clinical experience, years of dealing with women. And there's no better way to confirm your biases than to have you be talking to a patient who is in a relatively helpless position, you being the authority figure, the power figure, and having no external test except what you think is happening to that other person. And some of the theories that have come out about women from very eminent people in the field are, again, the same kinds of stereotypes that we talked about last week. For instance, Erik Erikson, who's done all this on identity, when he wrote in 1964, young women often ask me, what kind of identity can I have before I know who I will marry and for whom I will make a home? I mean, he's coming right out and saying women do not have an identity on their own.
I understand he's apologizing for that statement now, which is perhaps in response to the fact that people like you have called attention to the implications of what he said.
Well, in spite of his apology, how does this male bias damage us? I mean, how do you assess that damage?
Well, I think that what you would have to say is, what are the expectations for women? What do therapists expect us to be? Again, there's a whole literature which says that people are going to act in ways which are expected of them, and they're going to feel like the people they're supposed to be. So if you expect that somebody is going to be stupid and incompetent, chances are that person will behave in a stupid and incompetent way. Now, the question is, can male therapists or female therapists or any of us change that fast so that overnight, aside from the apologies, I'm sorry I said that about women in 64, I don't think it anymore, they have an independent identity, that people really have expectations for women which allow them their full humanity, creativity, courage, dignity, honor, joy, etc., etc.
Or just in a nutshell, which anticipate that a woman would not have health and goals in life defined in terms of subordinating her needs to someone else's needs. Because I think that's really the crux of the matter, that very often we have had the expectation that a woman should subordinate her needs to others, and that if she has trouble doing it, that is a problem which she needs to be helped to do, rather than to be helped to find some ways in which those others that she's trying to be helpful to can strike a fairer bargain with her.
let me ask you a question about that, because I think that's a really interesting thing, and I want to know whether, because I left clinical psychology, I want to know whether anything has changed since I've been in clinical psychology about that particular thing. When women had needs that they refused to subordinate to the needs of men, whether it be men who asked them to please type this something for them or make them coffee, or their husbands or their lovers or whatever, they were called castrating women. Which a term which has a long and tragic history from Freud and so forth and so on. I want to know whether the therapeutic community still uses the term castrating woman.
I haven't heard it since I was a resident, but I'm sure that there are places where one still can hear that term.
Because I think that that term summarizes the nutshell in another nutshell, because it says, if you really don't subordinate your needs, if you're assertive, if you say, I have an independent identity, then you are doing the worst kind of violence to a man.
All right, let me ask you both this. What needs to happen to make it better for women?
I think the continuing strength of the women's health movement is terrifically important in this regard, that informed, responsible women are doing considerable research into both theory and practice in psychiatric and medical care in many places in this country. They're asking a lot of hard, tough, embarrassing questions, and the questions that they're asking are stirring up considerable thought. I think that in itself is having large impact on how medical services in general, psychotherapeutic services are provided. I think another thing that's tremendously important is that the proportion of women among psychotherapists and among physicians is increasing. And I think that one of the outcomes of that is that, of course, we'll have better therapists and better physicians, because what discrimination means is that you take a less qualified person from the non-discriminated group instead of a more qualified person from the discriminated against group. So I see a lot of room for optimism. People raising a lot of questions. I think the kind of theory that was blindly taught, that was criticized by your paper, which was, I think, one of the really important ones criticizing it, is now in many places presented in a more tentative way, with room for discussion and room for people to raise their doubts.
I think that all of that is good, and to compare it to your analogy last week, which was really a beautiful one, if the water supply is poisoned and there's an outbreak of typhoid, you've got to treat the victims, the patients, and you've also got to find that water. You've got to find what's wrong with that water. I think it would be nice to have competent people treating the victims. I think that one of the things we've been discussing is, or we've been hinting at, is that there's a whole lot of incompetence in treatment of the victims. But I think that just using that analogy, that's a holding action. You're treating victims for typhoid because you haven't found what's polluting the water supply. And I think therapy, at its best, will always be a holding action. And what we have to do is we have to find that water supply and we have to change it. Which means for women, we've got to change the society which calls us inferior, which despises us, which treats us with such contempt. And when we do that, I think the need for therapy will really decrease dramatically.
I think it's important not to set up these two things in opposition to each other, because it seems to me that many of the women who are working for change are feeling all the stresses that are involved in change and all the stresses that may be involved in leadership. And I've seen many women who feel that because of their commitment to changing the water supply and their feeling that that's the place that they should be directing their efforts, who feel hesitant to get help for their personal problems, which they really might need very badly. In some cases, if you do battle, you're more subject to combat fatigue. And I think that it would be a terrible shame if those of us who have concentrated on work at either end of this twofold problem had to feel that we were in opposition to those who are working at the other end.
If you were looking for a therapist, and we have just a couple of minutes, what qualities would you look for? And how would you be able to tell if his or her sexism was interfering with your therapy?
I think the qualities that you want to look for are an ability to listen and give you a feeling that you're understood. I think that if there's any question about what's going on and whether there might not be some other perhaps medical kind of cause of your problems, you want to know that the therapist is able to consider those causes by virtue of her or his own training or having a consultant who does have that training. I think you want to have a therapist who's able to view things from several points of view, who can tolerate questions and disagreement, where you can have a mutual feeling of hashing things out when you start out with different viewpoints about some
and
aspect of
I'm
your
going to
life.
have to interrupt you. We're out of time again. Thank you both for coming. I've been talking to Naomi Weisstein and Ann Seiden on mental health care for women. See you next week.
Production funding provided by public television stations, the Ford Foundation, and the Corporation for Public Broadcasting.